Is it evening already? Oh, we have a night shifter here, huh? Or, all right. I'm just going to get my signal from, I'm good to go. All right. I'd like to start with a word of prayer, if you don't mind. Dear Heavenly Father, we thank you so much for this opportunity to spend a few minutes together and discuss, Lord, what you have blessed us with, which is a wonderful, fearfully and wonderfully made, and yet in society today we sometimes unknowingly move from the plans that you had in your creation in our bodies. And Lord, one thing we want to praise you for is that you have created our bodies so that many times when we follow your plan for our bodies, eat healthier, change our lifestyle to be healthier, our bodies are made, created to sometimes recover and heal many things that have been a consequence of years of intemperance, Lord. We just ask that you be with us just now. Give us your inspiration, give us your strength, and give us your will to continue to seek to be healthier. Lord, we pray this in your name. Amen. All right. So this afternoon I was asked to talk a little bit about diabetes. I know for those of you that went through the registration process next door, you filled out this pre-diabetes risk test. Now, for a show of hands, how should I say this? Anybody here know of somebody with diabetes? All right. So some hands of those may be because you may yourself have diabetes. But a lot of times families, particularly families, that is a risk factor for us if we have diabetics in our family. And we hear about diabetes as one of the common diseases around the world, but particularly in America. One thing I like to sometimes share is how diabetes was discovered. Maybe not how it was discovered, but how early physicians discovered diabetes or discovered when people had diabetes before we had blood tests. There was, back in ancient times, as far as even in like 6th century BC times, there's some reports, medical historical reports, that ancient East Indian physicians used to call a disease something called honey urine disease. And the way that they diagnose, and especially if somebody had certain symptoms, one of the things that they do is they'd have the patient urinate on the ground and they'd wait to see if ants would come. Because if the sugar content was higher, it seemed to attract more ants. And so now I'm not sure what happened if they saw the ants, if they knew what to do after that. But eventually medical knowledge has grown until we figure, that's the reason why there's a higher sugar content is actually our kidneys are trying to get rid of sugar levels in our body, in our bloodstream. So that's kind of interesting. I know that a lot of times when I talk to patients, particularly senior patients, about diabetes, a lot of times the word for diabetes in their vernacular would come out as sugar diabetes. And so I think that back in maybe the 40s and 50s, that was how people termed diabetes. They call it sugar diabetes, and they just knew that it'd be high in the urine. In the pre-diabetes risk test, it lists several questions, and in looking over the questions, a lot of these are fashioned to look to see if somebody's at a high risk. Now what that means is that if someone's at a high risk, they should probably get checked with a blood sugar, and some of you had your blood sugar checked today. We do know, like question number one, how old are you? Diabetes, particularly type 2 diabetes, tends to become more common as we get older. So that's why that age question is there. Are you a man or a woman? Men have a higher incidence of diabetes. If you're a woman, have you ever been diagnosed with gestational diabetes? So as many of you know, some women have diabetes just when they're pregnant, and then after the baby's born, the diabetes tends to go away. But what the doctor tucks back in their mind is that if they had it during pregnancy, there's a higher chance that sometime in their life they'll actually have diabetes when they're not pregnant. So that is a risk factor. Do you have a father, mother, or sister, brother with diabetes? Family. If you have a family member with diabetes, that statistically increases your risk. Or if you have diabetes or in your family, then definitely let your kids know that that's something that they should watch as well because they're at higher risk. Have you ever been diagnosed with high blood pressure? That is what's called an associated risk. So one of the things with diabetes, people that have diabetes, there is a higher risk of things like heart attacks and strokes, and high blood pressure has those same risk factors too. So what you don't want is actually both. If there's high blood pressure and diabetes, then it's like a double whammy of risk. So, are you physically active? And what is your weight category? Those last two, how that, with diabetes, we talk about sugar, but it's actually carbohydrate management in our body. Carbohydrate is a food element that we do need, particularly for fast energy. We need it, all our muscles need it every time we're walking, every time we're doing any activity, we need carbohydrates. It's like fuel is to a car. The problem is when the body has a hard time managing it and it starts going up higher, then it becomes a problem. And with sugar is a carbohydrate, and I think I was talking to one of you earlier that even if you don't eat a sugary snack, if you eat a carbohydrate snack, which would be potato chips or crackers and things like that, if you're not burning that carbohydrate off very soon, being very active, that extra carbohydrate in your body actually turns to glucose. So it's almost like having sugar as well. So, it was like, well, they're avoiding the sugar, but actually they're kind of getting that sugar in a roundabout way too. So, when it comes to, when people go to the doctor's office and some of the intake questions we have are trying to identify some of these risk factors. And the reason we do that, well, there's two reasons. Number one, for your health, if you have questions that are positive for this, then we worry about that. And the best time to catch diabetes is in its pre-diabetes level. So it's a kind of a zone. So we talk about diabetes, we talk about blood sugars, right? So typically the blood sugar, and the most accurate one, when they're checking your blood sugar, the most accurate one is something called a fasting blood sugar. In medical terms, the diagnosis of diabetes, the absolute bottom line diagnosis where a doctor can say this person has diabetes, is if they have two blood sugars, fasting blood sugars, that are above 125 or above. So now a lot of times what happens is somebody comes in and they're fasting in the morning, they check a blood sugar and it's 126. And so we go, oh, it's kind of high, it's suggesting you have diabetes. Technically what we should do is at another visit, check again. And if they have it twice, then technically they have diabetes. Now, does that mean that once they have diabetes, they have to start on a medication right away? No, not necessarily. In fact, at that level, they probably don't, if that's their highest that they are. But it does give the diagnosis of diabetes. That means in a certain situation, the blood sugar is higher, that statistically can lead to a higher level of the consequences. So the consequences of blood sugars being too high, of course, the end consequences, we worry about heart attack and stroke, but other consequences are kidney problems. So you hear about people having dialysis later on because of their diabetes. High blood sugar really works the kidneys hard. And if that happens year after year after year, then the kidneys start essentially pooping out, failing. All right. The other thing is that high blood sugar in the body is in the serum, which is in the fluid space all over our body. And that has effects on things like nerves. So you hear people that have numb feet neuropathy, maybe some of you may have like a grandfather that had his toe cut off or a foot cut off because of diabetes. And we'll talk about why that is. But part of that is because the nerves particularly the nerve endings furthest from the brain, which happen to be the feet, get affected first, and they start losing their sensation. Now, for some diabetics, losing sensation means they can't feel, and the feeling of their feet are less, but others, it feels like their feet are burning. It is what it is when we talk about peripheral neuropathy or diabetic neuropathy, it usually is that the nerves are not delivering the right sensation to the brain. So there are some diabetics out there that have a hard time walking because every time they step, it feels like they're walking on hot coals all the time. And others that literally can't feel anything. And that's important because pain is very important in telling our brain when to be careful. It's like if you step on something or you get a pebble in your foot, in your shoe, you know, it's like, ooh, get that pebble out. Well, if you can't feel that, you may just keep walking on that pebble all day long and not even know it. And that can be cause injury. The other thing is blood vessels. If they're subjected to high blood sugar all the time, then they tend to, the circulation, especially the smallest blood vessels, the capillaries, tend to have less ability to circulate, which means less oxygen, which means less nutrients. So if there is something that needs to heal, and the blood vessels that are affected the worst or the first are the blood vessels furthest from the heart, which happen to be the feet, again, which is the feet are usually the main focus for diabetic issues for circulation and nerves. We focus there. Yes? Oh. Yep, so now that you've heard of A1C, which is another diabetes blood test, it's also blood sugar, but it's different, okay? So a good way to picture this is in the bloodstream you have serum, which is just the fluid, which if you isolate, it's like yellow looking. You have the blood cells, which are red. The fasting blood sugar that you check today, or if you had eaten and they checked it, you usually poke your finger or something like that, and they say glucose. It's the free sugar that's in the serum floating along. The A1C is actually blood sugar molecules that come from the blood cell itself. So the red blood cells circulate, and they're bathed in the serum all through its life. And blood sugar, depending on how high the blood sugar is in the serum, some of them will kind of latch on to the blood cell itself, okay? So what we found is that in the blood test when they draw your blood, or it pokes your finger, what it does is it tries, the way that the test is run, it takes the blood sugar molecules, it takes away the free ones, and the ones just on that blood cell wall that got stuck on there, it pulls them off and that gives them a rating of how much there is on those blood cells. And so they usually do it in percent. And so if it's a high percentage, the difference between those two blood sugars is the ones that are on the blood cell take a while to change, because it has to be, the blood sugar in the serum could fluctuate within hours. So for example, if I check my blood sugar right now and it's 100, and I said, you know, I really want to increase that blood sugar, I'll eat a candy bar. Well, I eat the candy bar 30 minutes later, boop, 140 or higher. And that's because I just ate something, it went to the bloodstream, and there it was. Now, if I did the same thing with the A1C, it wouldn't change. In fact, if I had an A1C of, let's see, a normal A1C is under 5.7. So let's say I was at 5.0, and I said, I want my A1C to be higher, 5.5. Then what I'd actually have to do is probably, other than eating normal, I'd probably have to eat a candy bar every day for the next 3 months, at least 2 months. In other words, get my blood sugar the average to be higher consistently for 2 months. Now I get the A1C, now it will be higher. But because it takes longer for that concentration of those blood glucose molecules on that blood cell to change, it has to be bathed in a higher level for longer for it to change. So usually in the past, and I'm just talking like 10, 20 years ago, we couldn't officially diagnose diabetes with the A1C test. We now can, but before we couldn't because of that duration. Because what happens if, if they just had a little bit of a high blood sugar, it wasn't studied enough to know how accurate that could be. Now we know that we actually can, and we're pretty much in the ballpark. But sometimes we check an A1C, and then it'd be the level for diabetes is above 6.5. So if you hear people saying, "Oh, my A1C was 12," that usually, if the doctor's office got that, we'd be like, we don't even have to check a second blood test. That's diabetes, because an A1C of 12 means that person has had pretty high blood sugar for at least the last 2 or 3 months to get an A1C. If their blood sugar was really high, let's say 200, even though that's pretty high, you know, could it have been the big spaghetti dinner they just had at lunch? Could it have been the, 3 pieces of apple pie they had at Thanksgiving, and now you're getting the blood sugar that evening? That one meal could have brought it up, but an A1C, it usually means it's been a while. Okay, so that's the difference between A1C and so.
How do you use the A1C? Is it for diagnosing, or is it for?
We can use it now for diagnosing. What we usually use it for is how it gives us an idea, because there are nuances in diabetes, mainly for management. So let's say a good example of this would be a patient comes in and they get a blood sugar in the office and it's high. And I'm like, 200, that is not good. And I say, are your blood sugars high at home? And they go, yeah, every time I check it, it's pretty high. And so it says, so maybe it suggests we got to start a medication. But I said, well, before that, let's check an A1C. We check an A1C, and it's 6.5, which is still diabetes, but it's actually just barely diabetes. And we scratch our head and say, wait a second, why does this A1C look not too bad, but the blood sugars are bad? And so there are some diabetics that what happens is when they eat a meal, their blood sugar literally spikes really high, and then it comes back down, and then so it fluctuates a lot. And so it kind of really depends when you check that blood sugar, that the A1C actually says, well, they may fluctuate quite a bit, but overall it's not bad. So that helps us, how that helps us manage it, especially when it comes to diet, is then we can say, what are you eating that's shooting the blood sugars up so high? There are also some diabetic medications that are meant for those the people that have high blood sugar spikes. So there's some diabetics out there that they don't take insulin, they don't take metformin or those other medications, but they take a medication like with their meal to prevent that spike. And so, again, it's kind of a different form of diabetes, but there's some people that usually, where A1Cs really help is actually, it actually calls out some people, because some people say, oh, my blood sugar is doing fine, and they give you your record, and maybe there's a few numbers on there, but when you check the A1C, it's very high. You say, well, your blood sugars look good here, but your A1C looks like it's more in the 200s. And sometimes, 9 times out of 10, if I say that, usually then the patient that I'm with will be like, well, yeah, it's usually pretty high. And then they kind of confess that maybe they were giving me the good numbers and not the bad numbers. And so, but that can make a big difference as far as how I treat them. Also, if there are periods, so for some people, if there are periods of their blood sugars where they go down too low, then we have to kind of watch the A1C kind of gives us a long-term effect, and the blood glucose gives us short-term, and between the two, we can see, do they agree? And if they don't, why don't they agree? Yeah. So diabetes, a good way, as far as some people ask me, even those that have been diabetics for a long time, they'll ask me, what exactly is happening with diabetes? Why is my sugar high, and my husband, who eats the exact same thing, he doesn't have diabetes? Why doesn't he have diabetes? We're eating the same thing. Part of it has to do with how the body manages sugar or carbohydrates for fast energy. And so a nice description that I usually give is when we eat food, any type of food, part of it goes into our body, we absorb it as carbohydrates. The body, when we're absorbing that in our stomach, the pancreas, which sits behind our stomach, monitors that and says, and kind of predicts, this is how much blood sugar or carbohydrates my body is absorbing. And what the pancreas will do, it will produce the right amount of insulin. Now, insulin's important because, like I said, to the cell, any muscle cell, brain cell, bone cell, brain cell, any cell in our body, it needs that glucose carbohydrates that we're eating for its energy, like fuel. But the fuel doesn't get right in the cell. How the fuel can be floating in the blood right over here, and the cells right here, the muscle cells here, and the muscle cell innately doesn't know how to get the blood sugar in it. All right? So what happens is it needs it's almost like a key to connect the two, and that's insulin. And so when the pancreas makes insulin, now you have a glucose molecule here, you have an insulin molecule over here, and the insulin tells, essentially there's these receptors on the muscle cell for insulin. The insulin connects there and says, hey, there's glucose out here for you. And when it connects there, then the muscle cell knows how to get the blood sugar in there. So a lot of times when people are first diagnosed with diabetes, they don't know that they have diabetes and they just get sick. Usually when people have diabetes, particularly type 1, which is their pancreas just doesn't even make insulin, they get sick. And what happens is they're sick, but they don't have a fever. They're not coughing, but they just feel horrible. Maybe they're throwing up. We bring them to the parents bring them to the hospital. They check their blood sugar. It's like 400, 500, something like that. And they go, oh, you're diabetic. But the reason is that all that blood sugar is sitting out here, but the muscle cells don't know how to get it. So the thing is, the body is just feeling sick because it's like it's starving. Essentially, the cells are starving, and the energy is right there, building a high level, but it can't get in. And so what insulin does is it gives the message to the muscle to get the glucose. Now, in diabetes, in type 1 diabetes, those are usually diagnosed in younger people, usually in their teens or younger, and that's when, for some reason, their pancreas just stopped making insulin. Now, those people, because they don't have insulin, their treatment is insulin. So that's when you see a young person injecting themselves, that's what they're doing. Most common diabetes is type 2 diabetes. Usually happens in adults, usually diagnosed in 20s and more in 30s and on up. And what happens is that the person still makes insulin, but the communication is not getting through. The insulin gets on the receptor, but for some reason the message isn't getting through to tell the cell. So actually with people with type 2 diabetes, when you're suspicious of that, if you were to check an insulin level in that person, it would probably be higher than normal, because their pancreas is like saying, well, if one insulin molecule is enough, let's make more insulin, and just like, let's just tell the cell, this is how to do it, this is how to do it over and over again. So actually the insulin level is higher, but still the glucose isn't getting in there. And so for those people, the different treatments that we use, like if you've heard of the different medications, well, of course, with diet, you're limiting how much glucose you're actually putting in your body, into a good level that's easier for the body to handle. If you're with exercise, you're burning that glucose, so the glucose load is less in the body. The medications that we use are things like metformin, which actually causes the body to absorb glucose less in the intestine. There's a medication called glyburide, which actually causes the pancreas to try to make more insulin. There's other medications that try to make those little receptors to insulin more sensitive. The new ones that you hear about, like you hear about Ozempic, that people are also using for weight loss, those actually work on, they mimic the hormone that our body makes when we get full. So when we eat enough food and our stomach gets full, it will signal through a hormone in our brain saying, hey, you're full, stop eating, everything kind of, the intestinal tract slows down a little bit. So when they're taking something like Ozempic shots, they're essentially giving their body a mimicking hormone dose, telling their brain, you are full. So their appetite will drop. There are some side effects to that, and we don't really know the long-term side effects yet, although it's being used quite a bit now. So one of the main side effects you may have heard, because when the diabetic medication Ozempic first came out, you'd hear news of Hollywood stars using it to lose weight. Every once in a while later on, you'd hear some stars talk about how they had to stop because of intestinal obstruction, or they're just nauseous all the time, because one of the things that hormone does is it causes the intestinal tract to slow down, like we're full. Some people, it slows down so much that things actually stop, and then they get obstructed, and that can be a trip to the hospital. So, so when we identify some of these risks, some of these things that we can do, because you've heard of people that say, hey, I was diagnosed with diabetes. A lot of times the question I get in the office is, can I do something so I cannot be diabetic? Can I reverse it? And the answer to that is yes. But on your diagnosis list on the computer in the doctor's office, they won't take it off. Because the reason is, two reasons. Number one, there is a situation with which that person came in with that got the diagnosis of diabetes, that if they were to mimic that again, they'd have diabetes again. So it means that that person at some point could get it again. Some people, for example, a good reason for this is weight. Some people, many people, their diabetes has a lot to do with the weight. And we found out that there are studies that when people get overweight, the more fat cells that are active in their body, that insulin becomes less effective to tell the muscles and the other cells how to use the insulin. We call it insulin resistance. You may have heard that term before. But for some reason, when the fat cells are more prominent in our body, the pancreas actually has to make more insulin to make up. The communication just isn't as good. So some people literally, if they lose a certain amount of weight, I had a patient once, more than once, where they'll say, if I can keep my weight under 160, I'm not diabetic anymore. So our whole plan was how to keep that person's weight below 160. But are they diabetic on the chart? Mm-hmm. Because if they go above 160, then it tells the doctor or the healthcare people that beware, if they go above 160, they probably are diabetic and you want to really address it. It also, for medical insurance purposes, if that diagnosis is there, that means that at a certain point they are diabetic, then they cover the monitoring testing that you need to do. If you were able to eliminate that diagnosis, then insurance would say, okay, then you don't have to check them for another year. And the doctor would be like, no. They're just at that weight. We really want to check them every 3 months to make sure. But the insurance won't cover it unless you have that diagnosis. So there's a couple reasons we do that. So what will happen is that if somebody is able to change their diet, reduce their weight, and essentially get to the blood sugars that are no longer diabetic, then what we call them in the medical terms is a diet-controlled diabetic. So does the diagnosis of diabetes or prediabetes mean that you have to be on medication? No. Does it mean that even if they are solidly in diabetes, can they reverse it? Yeah, they can. The majority. Now, type 1, usually if the pancreas doesn't make insulin, then insulin becomes part of their life most of the time for their lifelong. But they can, with diet and exercise, make it so they don't need as much insulin. So they don't have to inject as much. All right. Any questions first on diabetes in particular? Yes?
If you have a set AC of 6.5,
Mm-hmm.
that's not bad.
It's not bad. For somebody with diabetes, the actual goal medically, the goal is to get under 7. So technically, somebody with diabetes and they're under 7.0%, we call them adequately controlled diabetic. Now, is it the best health? Not yet.
Well, if you have that consistently, looking down to 6 or something, could you get away without your medication?
The only way to do that is to actually, in a controlled way, reduce the dose or stop the medication, check 2 months later, and that, as far as A1C. Now, the other way, of course, is while you're doing that, if what I tell patients is that if they really want to reduce their dose to the purpose of reducing, to stop the medication, number one, we go over what are they doing to bring it down naturally with their exercise, regular exercise, and what they're eating. then what we do is we track their blood sugars daily and see, are they at a level that is low enough? So if their blood sugars are like, oh yeah, it's 120, 115, 90, something like that, it's like, okay, if on medication you're in a non-diabetic looking blood sugars, then I usually will say it's pretty safe to, let's try, especially if you've been doing something about it. So if we can, I usually advise reducing the dose. So if they reduce the dose and they're checking their blood sugars every day, they'll see if their blood sugars rise up. If it doesn't, or rise up very minimally, and we come back a month later and it's like, okay, I cut your medication in half and your blood sugars are still in that range, maybe a little bit higher, but still in that good range, try off medication and see. So now with the thought that if they stop or they change the dose and their blood sugars jump up, they can just return onto that dose, continue with their diet and exercise program, maybe lose a little bit more weight if that's a factor for them, and then we can try again. Mm-hmm. Yeah. Good question. Good question. So if someone's, yeah. Yes. Oh, good. Thank you very much, Mike. So the question is, first question is, how important is to take blood sugars, particularly if it's we know with diabetes that a fairly regular blood sugar is important, some day by day. In someone with prediabetes, it depends. How's that for an answer? It depends on the patient. Here's why. Medically speaking, we usually will recommend something on the order of every 3 to 6 months to check a blood sugar for prediabetes. As long as we tell the person, because technically, so the difference between statistically in medical research, prediabetes is that level before diabetes. Now the demarcation is where we see an actual statistical increase in the complications. So it's the diabetes level, so in blood sugar it's 125 or over. So if, statistically speaking, if somebody's consistently above 125 blood sugar, fasting blood sugars, they have an increased risk of heart disease, strokes, heart attack, peripheral neuropathy, kidney, that sort of thing happens after that level. So below a 120, technically they're not statistically increased. So if they're not statistically increased, but they're getting close to that level, we do want to monitor it, we do want to address it, but they're not statistically in danger yet. They're almost like in danger of being in danger. You see what I'm saying? So just like if somebody came in and if you have the range of prediabetes here, diabetes is up here, if they came in just barely into prediabetes, we'd say, okay, analyze what they're doing, and as far as diet and exercise, and just kind of see if in 6 months, are they moving up? Are they moving up? So there, it gives us a little bit of leeway time before statistically they're actually in danger. Yeah. So medically speaking, we usually will tell people every 3 to 6 months we should check your blood sugar if you're pre-diabetic. Now, in reality, now there's some people that say, as soon as they hear the word pre-diabetic, they're like, oh my, I need to check every day, I need to do that. And so sometimes we will, depending on the comfortability of what the patient wants to do, we'll try to go to bat for them to the insurance, because the insurance companies a lot of times, some insurance will cover the glucometer and the test strips, and some won't in the pre-diabetes level. So some people will say, I don't care about the insurance, I'll pay for it myself, I just want to check. Then we want to be reasonable with them. And sometimes if they check their blood sugar often and they're really using that to see, if I eat this, what does my blood sugar do? And I eat this, what does my blood sugar do? That combination of checking may actually mean that they get a grasp on how their body handles different foods very quickly. And so it gets them on their plan on how their optimum diet soon. So in that case, it may be worth it to invest in checking sooner. But as far as statistically speaking, for that person in danger, standard of care is monitoring every 3 to 6 months. Yeah. The second question was, when is the best time to take blood sugars? So the diagnosis of diabetes is based on fasting blood sugars, which is essentially what is the lowest. So fasting blood sugars are, in the lab term, is at least 10 hours without anything to eat or drink except water. Okay, so by that time, so what the physiology, we eat food, as our body absorbs it, the blood sugar goes up. Now our blood sugar wants it down here, like 120 or 100 to 120, but let's say it goes up to 160 because we ate something. Now typically in a non-diabetic person, the pancreas, the insulin, all that will bring that blood sugar down to the normal level by the next meal. So in a non-diabetic, you eat, it goes up, and then by the next meal it comes down, and then you eat again, it comes up, it goes down, and within that, the body's able to get its energy, which is another reason why snacking sometimes in a non-diabetic may not be good, because it doesn't allow that blood sugar to come back down to normal, depending on what you eat. I mean, there's a difference if you have an apple and if you have a bag of chips, which is carbohydrate loaded, or cookies, all right? So what we're trying to get with a diagnosis is that bottom level, how low, what has the body been able to get to normal? In a diabetic, because the body's having a hard time bringing it down, what will happen, they'll eat, and the blood sugar will stay kind of high, and the body's trying to bring the blood sugar down, and by the next meal, it isn't down, they eat again, and it just stays up here. So the best time where most people don't snack through the night, usually, first thing in the morning after they fasted through the night, it usually is easiest for somebody to go 10 hours without something to eat or drink, except water. And so they get the blood sugar then, and they kind of get that lowest point. Yeah. Mm-hmm. So for a normal range for non-fasting blood sugar is accepted as under 140. Mm-hmm. Well, wait a second, hold on. Why did I put that here? No, diabetes is I'm sorry, it's for diabetes is above 125, for pre-diabetes is 100 to 125 repeatedly, and for normal it's actually 60 to 99, 60 to 100. Now we also accept up to 100, up to 120. It's kind of in the early pre-diabetic, it's in the pre-diabetic range, but a lot of times we'll see that as not concerning if it's like an event like we have here today. We check it if it's below, is 120 or below, we usually say, okay, we don't usually label it pre-diabetic right off the bat. But typically normal now, a good solid normal is 60 to 100. No, fasting. Did you say non-fasting? Oh, non-fasting, I think that's where the 140. Usually, if it's non-fasting, it will be under 140. Usually, the diet, there is if it's over 200 on a non-fasting blood sugar, we can use that actually, medically speaking, as a high number to diagnose diabetes. If it's over 200 non-fasting, and we check it again when they're non-fasting, or we get a fasting one that's it's too high, we can use the non-fasting blood sugar over 200 as one of those diagnostic levels. Thank you. All right. Any other questions? All right. Maybe 2 minutes on any questions non-diabetic. Medical questions non-diabetic. Yeah. Yes. Yeah, that is a risk factor too for hypertension. Mm-hmm. Yeah, if they, so women that have prediabetes, when they've done studies in the past, if you took a group of women that all of them had gestational diabetes, and then a group that didn't. Later on in life, 20, 30 years later, there'll be a higher percentage there's some in either group that will become diabetic later on, but there'll be a higher percentage in the gestational diabetes group that will become diabetic. So we're not exactly sure why that is, as biochemically. It could be also, so it could be that just the stress of carrying a baby and all that, because stress has something to do with diabetes. That the body has to do more things, and that is just throwing the control off a little bit. But we don't know, is it a hormonal? It seems like if it was strictly a pregnancy hormonal thing, then there wouldn't be any difference between those that had gestational diabetes and no diabetes during gestation. Oh yeah, they'll watch it. Usually, what will happen is if they know ahead of time that the couple's planning to get pregnant and she had gestational diabetes the first time, usually most OBGYNs will start talking about what's your diet and exercise even while you're planning. The best way to plan for that second pregnancy is to look at your diet and exercise before you even get pregnant. Can you focus, knowing that there's a likely chance you'll become gestational diabetes, can you control it with diet and exercise the next time? With gestational diabetes, it has its own set of unique complications. For example, a common one for moms with gestational diabetes is their babies tend to be born higher poundage. And so then we have to then the C-section rate is higher because they can't get them. Sometimes there's a higher rate that they can't get them through the birth canal because the babies are bigger because of the higher sugar. For some reason, that increases the weight of the baby, the fetus. All right? All right. Well, I thank you so much for your attention today. I hope we all learned a little bit more about diabetes, and I'm glad that hopefully many of you were able to take that health age check off, because a lot of the diabetes risk some of the diabetes risk factors are there too. So. Oh yeah, please. I don't.
The diabetes on that.
Yes. Oh. Okay.
Do you have the details on that? Yeah, in the,
It's inside of it. Okay.
yeah, it's on the next, actually next, Sunday,
Excellent. Great. All right. A lot of times when I look at what dietitians, a lot of times when a patient comes to the office and we diagnose them with diabetes, a lot of times the things we offer is a referral to a dietitian to learn about what sometimes we'll call a diabetic diet. But actually, the diabetic diet is actually a healthier diet. And so a lot of times I'll tell people, I think it's a disservice to call it a diabetic diet. It really is a healthier diet that even non-diabetics, we should actually follow more like. So even if you're not pre-diabetic, attending a class like Diabetes Undone is actually a benefit. Mm-hmm. Mm. Yeah, so especially you mentioned about fruit. How does diet have to do with that? And a lot of that has to do with the diabetic individually. Because in either whatever they do, healthier is always better, but they should monitor their blood sugars. Because there is quite a bit of natural sugar in fruit. And so somebody who's what we call a very brittle diabetic, they don't eat very much and their blood sugar goes way up, they get kind of lightheaded and all that stuff. They could actually replicate that if they ate enough watermelon or if they ate enough strawberries. So sometimes, although it is good, it is important for that person to monitor and see how their body responds to each thing they do. And as their blood sugar, because of their diet and exercise, the baseline starts going down, in other words, becoming more managed with diet and exercise, then they can actually eat more and more of the natural sugars like that, and their body can handle it. But there is a, depending on how diabetic or how, like if it's somebody that's taking 3 different medications, and when they come off the medication, I'll usually tell them, do diabetes undone, monitor your blood sugar, and really get to know how your body responds to those different things. And so if it looks like, oh, you know, when I eat a big bowl of strawberries, my blood sugar goes through the roof, and my doctor's telling me to give myself more insulin, then maybe start with a half a bowl of strawberries. But eventually, when the baseline blood sugar gets better overall, they'll be able to eat as much as they want. Yeah, yeah.
Monitor that. What you want to say strawberries, okay. I'm going to eat, say, a couple of strawberries. Do I check my blood sugar right after I eat it? Find out if that's the
So
sugar.
the question is, how soon after you eat something do you see the blood sugar increase? Usually we have to wait a little bit. So depending, usually we'll say an hour to 2 hours afterwards will give us kind of a reflection of what we just ate. There is we'll say something like 2 hours postprandial. Postprandial means 2 hours after we ate. And that's typically, it's going to give us about the blood sugar peak of whatever we ate. So it's about an hour to 2.
Eliminate a certain item, then when we eat more items, let's see what happens one.
Mm-hmm. Oh,
Determine which roles are.
so if you eat like a lunch, if you eat like a lunch with 3 items, you check a blood sugar 2 hours later and it's high, you're like, wow, it's too high. Which item did it, right? You can, sometimes it's hard if it's all together, but you can kind of, it's the carbohydrate component that's going to bump the sugar. So if one of those items was ice cream, and the other one was, well, I had an apple, celery sticks, and ice cream, it's probably the ice cream is the biggest one, right? So it's almost, and then what you can do, and what people will do is they'll say, okay, well, next time I eat that, I'll eliminate the ice cream, do the same thing, and then check. And now you may get a little bit of different, so there's a little bit of sleuthing involved, you know? Yeah. Okay. What's the difference between natural sugar and granulated sugar? Well, granulated sugar originally came naturally, but the problem is when they process it to become granulated sugar, it's actually quite concentrated. So the processing, and it's pure, so it absorbs much faster, and so it doesn't come with like the natural, when it comes naturally in like a fruit, you've got fiber, which actually helps reduce the sugar. Okay, so when you eat the fruit with sugar, and it's watery, most fruit is pretty watery, juicy, you get hydration. The fiber in your stomach and intestines reduces the absorption rate of the blood sugar. So the blood sugar actually, as is absorbed from the fruit, increases much slower than if you were to eat ice cream that has the granulated sugar. It's just all in your system right away. So there's a bigger sudden spike. And so that is one of the things that we worry about when it comes to people with diabetes. The height is important, but also how fast it spikes up and how fast it comes down is also quite stressful on the body. If there's drastic ups and downs, that's actually quite stressful as well. So it's a little bit more even when it comes to foods that we eat that are closer to the source of how it was grown. It's a lot smoother. It seems to be absorbed with a little bit more of a gentler slope. Hmm? Yeah. Pardon? Okay. Hmm? Well, I don't know if it's directly. It does slow down digestion in general. Because what happens is that's why, when some people ask, when's the best time to drink water? And if they're drinking plenty of water through the day, some people will say, is there a better time to drink water than others? And there actually is when it comes to digestion. For digestion efficiency, it is best actually not to drink fluids when we eat. Okay, when it comes to that, because what happens is that when we mix food, now in a restaurant, it's pretty customary. They ask, what do you want to drink before you even order your food? So the assumption is you're going to be drinking before, during your eating, and even after you're eating. The problem with that is that the full digestion can't occur until the fluid is absorbed. So fluid is absorbed first, and then digestion can really occur. So whenever we mix the two, like traditionally, we eat and drink. When we do that, the food actually sits and doesn't digest much until the fluid is actually absorbed, and then digestion hits, which then plays into, like, for example, effective sleep. If you eat a big meal and you drink and then you try to go to sleep, because digestion is prolonged, it may actually interfere with sleep. So by that, indirectly, it may actually reduce the time of digestion. We usually don't have that as a suggestion for people if they eat something, just drink a lot of water. And if they're dehydrated, it may be worth it to drink more water at any time. But as far as trying to stave off the blood sugar, I guess it's something that could do, but it's not something that we typically tell them to do. Yeah, yeah. Well, yeah. Then her conviction, it's going to have to be her. But probably if the fear of high blood sugar and diabetes and all the things that if that's not enough. So some people, fear of what the consequences are is a good temporary motivator, though it tends to be temporary. Some people over time, usually if they feel okay at 500, it usually means their body has actually adapted. It's been that long. They've probably been diabetic for years, and as the blood sugar just rises and rises, their body just adapts. And sometimes they don't realize that what they feel is okay, if their blood sugar is, now if you took that person that's 500 for a long time, and you could give them medication and you drop it to 120, ideal, they will probably feel horrible. They will feel at that point like you and I would feel if our blood sugars were at 50. It's like too low, hypoglycemic, because their body has adapted to that high. Now, even though their body function-wise has adapted to that high, they still are in the higher risk for all the other consequences still at that point. So for them, usually, if they're open to it, bringing it down slowly to the normal level they may, sometimes when people do that, then they realize, oh, I actually didn't feel good all that time because I feel so much better now. Sometimes their motivation has to come from a different direction. Yeah, and sometimes, sometimes although the information is there, sometimes the Holy Spirit, sometimes the best thing that we can do for them at that point is to pray for them, because if the Holy Spirit can reveal to them a different motivation, then sometimes that's the key.
The other is putting them in a position where they don't have that control, like a regular control. Where they're really bad, and they become fully. If they're open, if they really want, maybe they can't do it on their own. So the question is, how much do you want to do this, and you should be willing to go someplace where it's controlled for you. Would that help?
Yeah.
And if they're open to that, then what they'll probably do is just put them on a fast.
Does hypoglycemia have anything to do with diabetes? Yes, in the sense that usually we use the term hypoglycemia in diabetes when a dosage of medication or they haven't eaten at all. And so it's like, for example, a common time is when people are learning to do their insulin with type 1 diabetics. They find out they're type 1, giving them insulin, and it turns out that they figure out that, oh, if I don't, the insulin dosing is based on when they're going to eat. And if they happen to skip a meal or two and still give themselves the insulin, then the insulin will make them hypoglycemic. And so I had in my one of my medical school days, I had a lecturer who was diabetic. He was type 1 diabetic, and one day he didn't show up for class. And so we're there, and we're like, hey, where is he at? Okay, well, half the class is like, well, 10 minutes are up, we're out of here. The rule book says if it's 10 minutes, we can leave. And some of us are like, well, we got to check on him. Where'd he go? Because he's usually never late. And then right by the elevator, he was sitting right by the elevator, and he looked like he was sleeping. So he said, hey, professor, are you okay? And he's like, He barely, we could hear him grunting, but he wasn't. It's like, oh, something's wrong, because he wasn't responding. So somebody ran to the secretary's office and said, hey, professor's not responding. He's sitting over here. And she just kind of rolled her eyes and said, oh, he gave himself the insulin, and he didn't eat this morning, I bet. And so she went over there with a soda and put a straw in and put it in his mouth, goes, okay, professor, just sip it in. And you could see it just sipping little by little. And after about 10 minutes, he's like, oh, thank you. And he'd gone hypoglycemic to the point where his body was essentially shut down. It's like, I don't have any energy, so I'm not going to move. Boom. And so that can happen in diabetics, but it's usually because because the problem with diabetes is usually hyperglycemia. So if it's hypo, it usually is because something got overestimated, usually a medication dose. I'm not aware of any research that has connected the two. Yeah.
When we were asking the question about monitoring foods, I've never seen this done before until my son did it. And his recent bride's brother gave them, was it a 7-day, 14-day? I don't remember how long it was. But it was a monitor that they wore. And he bought for them as gifts so that they can just kind of see what and they're both very healthy people, but just to kind of tweak and see the nuances of what they ate. And they were kind of surprised at different things that they ate, how it elevated their sugars. Not out of control, nothing to do with diabetes, but just to get an understanding of how certain foods and combinations of foods affected their sugar. So going back to your question, there are those devices. I don't remember how much it costs, but some people are wearing, this is like life for them.
I have a grandson who's diabetic.
Yep.
He has one. What a blessing it is to have that.
No, it's nice. A common name, there's like three or four companies out there that make these. These are, they call it CGMs, continuous glucose monitoring devices. So the traditional one is a glucometer. You have to buy the test strips. Those are the costly ones. I think it's like $100 for like a month worth of test strips. But that one is where you poke your finger, you get your little droplet, and you check it. These are now, the technology has grown, so you can get, it's like a plastic little disc that has a little sharp, it's like a fiber in the middle of it. And they literally, you can see some people, they walk around, they'll have this little disc on the back of their arm. And it goes, the little sharp part goes just under the skin. Now once it does that, there's a little poke when they put it in, but it sticks on there. And I think they're usually good for anyway 3 days to a week, depending on the brand. So you stick it on there, and some of them come with a monitor, but some of them, you have an app on your phone, and so when you want to know your blood sugar, you literally just wave your app over that little disc, and it gives you your blood sugar. So you could literally walk away. Yes. Oh, is it every 2 weeks? I change it. So yeah, so they're getting longer, and as brands come out, there's still the cost for that system is still more expensive than the glucometer, the traditional system. So insurance companies haven't been really agreeable to pay for, like the common one that most people know is called Dexcom, the CGI monitors. And so they haven't been covering them except for if somebody is continually not controlled, then they a lot of times will cover it. Or the people that use insulin, they usually will cover it now. But it's, in the medical market, all it will take is enough time and enough brands that will come out that the price goes down. And as soon as that price for monitoring your glucose on that Dexcom equals the glucometer will pretty much go the way of the museum. You'll never see them again because it's just so much easier this way. And the thing is, they can program these things to actually transmit to the doctor the report. So, the doctor can actually give them a call. Hey, did you know I know you haven't been waving it that much, but our office is getting these reports, So, so they think it's going to be, better. But, so some people, so people can buy them, but again, those little discs are pretty costly. It's going to be a few $100s a month, I think, for somebody. The group of people that are really trying to do that now are athletes. So athletes in their training are really, they're starting to say, okay, what's the optimum glucose level after I train, and how much should I carb load, and so they're starting to do this, and because it's easy to, you don't have to poke your finger, they're starting to get theories as far as what's the optimum for the athleticism. So athletes will also wear this. It's like, wow, there's a lot of people running with these things, and they're not diabetic. They're just that level of an athlete now that they're doing that. Yeah. So, all right. Appreciate your attention.